bring all the equipment like Conrad had mentioned. And then I passed the test of time, bought the new tower, and now in the last few years we have got everything from shoulder to knee to multi-ligament reconstruction to shoulder stabilization we are performing. This is my team. We have 4 research projects running at the moment, one of them which has been approved by the ethical committee and will be published soon in one of the European journals which has been accepted. And now we are fully equipped, as I mentioned, to do everything from revision cases to primary cases to high athletic sports player doing ACL reconstruction, and that's the result. And that's my team. Zishan is sitting here. I'm very proud of them. And I'll move on to the concept about anterior shoulder instability. I'll finish this talk in 5 to 6 minutes, and I'll tell you the difference between the type of patients we treat in Europe, where I did most of my work, and what are the difference between the pathology in Pakistan. So shoulder is the most mobile joint, as Reece already mentioned, just like a golf on a tee ball. And we need to understand 3 concepts about shoulder. What's stability, which I've done for young guys, because I think it's very important that all of us should understand that if you have a vision and you want to achieve more in your life, you can achieve it. I was a practicing consultant since 2012 in England. I'll just skip this slide, not telling about myself what I do. But I just want to show that I was working in this practice in one of the best hospitals in England which was nominated one of the best hospitals in 2015, 16, 17. And I decided that I would move back to Pakistan, and I came in 2014 and 13 and 15 and 16 as a visiting consultant. Did not got the job, was not appointed in any government hospital, all by myself with one vision, that if I have a training, I'm competent, and I know my work, I will achieve my goal.
What's the problem? It's the acceleration phase which has got the highest and the greatest angular velocity across the shoulder joint. The rotational velocity is almost 7,000 degrees per second. Shortest, but the highest risk of injuries. Following that, the deceleration and follow through are almost 0.35 seconds. But as I mentioned, this is the one that leads to more damage. So what's the history and clinical examination with patient when you see them in clinic? Young patients, professional sports player, pitcher, throwers, especially in the United States and European countries, they will come to you with pain based mostly on the posterior aspect of the described it as an ossification of the posterior glenoid. And not until 1992 when Walsh actually described the internal impingement is recognized by lesion in the posterior superior aspect of the shoulder, and was called as an internal impingement, just like external impingement. We need to know a little bit about pathophysiology and biomechanics. These are the 3 principles around the shoulder joint which we need to understand: kinetic chain, Grover's paradox, and scapular dyskinesis. I would leave the rest of the 2 because the shortage of time is too complex to cover everything. But if we look into the kinetic chain, a kinetic chain is actually a chain that transfers the energy from the leg strength, body rotation, core strength, scapular rotation,